You sit down for a small meal. Within minutes, your stomach swells outward, becoming tight, hard, and physically painful. You find yourself unbuttoning your pants or searching for oversized clothes to hide the protrusion. To anyone else, it looks like a sudden 6-month pregnancy, forcing you to plan your entire social life around the inevitable expansion of your waistline. When you seek medical help, the physical distress is often categorized as simple trapped gas. You are told to change your diet or try an over-the-counter relaxant, leaving the cause unaddressed. This chart isolates data from clinical CT scans of these episodes. It shows only 25% of people with visible distension actually have an increase in gas volume. The remaining 75% show no extra gas at all, despite their stomachs being measurably larger. If the stomach isn't being inflated by air, then the standard gas-based diagnosis fails to account for the physical expansion. The discomfort is real, but it originates from a mechanism that standard imaging often misses. Doctors must first rule out organic diseases. This technical view shows the gallbladder and bile duct, areas where gallstones or blockages can cause acute pain. However, these structural issues are rarely the cause of chronic, daily bloating. For most patients, endoscopies, standard abdominal ultrasounds, and routine blood tests will return completely normal results. The gastrointestinal tract appears structurally healthy. The tissue is not inflamed, and the organs are in their correct positions. Because the physical organs are intact, the investigation must shift away from the stomach's anatomy and toward the neurological signals that control it. This diagram illustrates the brain-gut axis, the two-way communication highway between your central nervous system and your digestive tract. Your brain is constantly monitoring the state of your intestines. Factors like severe stress, chronic anxiety, or a previous gut infection can alter these signals. This creates a state where the communication becomes disorganized, leading to misperceptions of what is happening inside the body. This leads to visceral hypersensitivity, shown here in the abnormal sensation callout. The nerves in the gut become so sensitive that they interpret the normal, routine stretching of the stomach after a meal as a significant threat or intense pressure. The pain is not imagined. The brain's threshold for sensing volume has been reset. It perceives a standard meal as an emergency, which then triggers a defensive physical reaction. When the brain misinterprets this normal digestion as dangerous pressure, it sends a faulty command to the muscles that surround the abdomen. This erroneous signal initiates a protective reflex that moves the muscles in the wrong direction. This diagram shows the normal viscerosomatic reflex. When you eat, the diaphragm, the muscle above your stomach, should relax and move upward. Simultaneously, your abdominal wall muscles contract. This coordination creates more vertical space in the torso, so your stomach doesn't have to push outward. In patients with abdominophrenic dyssynergia, the reflex is reversed. As shown in the lower diagram, the brain commands the diaphragm to contract and move downward, while the abdominal wall muscles relax and loosen. The descending diaphragm acts like a physical piston, pushing the abdominal contents down and out. This muscular error is what creates the visible distension, explaining why your abdomen protrudes even when gas levels are perfectly normal. Anti-gas medications target air bubbles, but they have no effect on a coordinated muscle contraction driven by the nervous system. Dietary changes, such as a low FODMAP diet, can help by reducing the initial triggers. As shown in this view of the colon, certain carbohydrates ferment and draw in water, which stretches the intestinal walls. By limiting these foods, you provide fewer signals for the hypersensitive nerves to misinterpret. While diet calms the internal environment, it is only one part of the recovery process. Reducing the trigger does not automatically fix the underlying muscle reflex. Long-term relief requires treating the abnormal reflex itself. Physicians may use central neuromodulators, which work to raise the brain's pain threshold and normalize the communication between the brain and the gut. Physical interventions like biofeedback and diaphragmatic breathing are also used. These exercises retrain the diaphragm and abdominal muscles to respond correctly to the presence of food, breaking the cycle of protrusion. Recovery is a gradual process of retraining the nervous system. It requires a diagnostic approach that looks beyond simple gas and focuses on the complex interactions of the gut-brain axis. Your distension is a measurable, documented medical condition called abdominophrenic dyssynergia. By addressing the neurological signals and the muscular reflex, you can move past temporary fixes and begin a targeted pathway toward lasting relief.